Perioperative, we're going to talk about. It's a specialty area. How many of you have been to OR this time? Everybody? Everybody? Some people? Okay. For an assignment, the matrix that you did of pre-op, intra-op, post-op, if you haven't done that, go ahead and make a matrix for that for an assignment for perioperative. And the main thing you got to know about that is safety and the responsibilities of each of those roles. You need to know the difference between who is responsible for before the surgical, during, and after. Okay, so pre-op. Does anybody know when pre-op starts? Before surgery, good. Okay, it's when the person has made a decision to have surgery. That's when pre-op starts. So, and it continues until that person is transferred into the OR. So that is all considered pre-op. Okay, so intra-op is going to be once that person goes through those doors into the OR room. That would be intra-op, and that will continue until they're admitted to PACU, which is your post-anesthesia unit. Okay, post-operative starts when they're admitted to PACU, and it is done when their recovery is complete. So it even goes to while they're at home. You know, it's post-op is post-operative all the way until they're recovered. Okay, settings. Outpatient ambulatory settings are now the focus of most surgeries. 70 to 90% are done in outpatient surgery. What are some of the reasons that you think that that's become more popular?
Cheaper.
That would be number one. I would put the money, because some of the others I'm like, really? So what are some other reasons people give?
Convenience.
Convenience is another thing. Yes, they believe it's more convenient.
Reduced risk of infection.
Yeah, there's a lot of nosocomial infections now. People getting it, especially if they've gone in and swabbed in surgical suites and stuff, and they find MRSA and they find all kinds of stuff. So it would be less infection, yes. What do you think another thing might be? They say convenience of the patient, less time, and can be home sooner. But I'm thinking, ooh, I just soon leave them in the hospital, let somebody else take care of them. But for some people, it's less time off work. So what would be some of the struggles with outpatient surgery for you as a nurse?
Non-compliance. Like as far as like their restrictions and stuff that they're supposed to abide by, they probably.
Or even then, like keeping the surgical room clean, like doing what they're
supposed to do. Think about patient-centered. If you're patient-centered, what would be so hard if you got okay, let's say you got somebody coming in and they're going to have, okay, you got a kid coming in, it's going to have their tonsils out, you get them in that morning, you got to get them out by that evening. Teach.
Try to educate them.
Yeah. That is like ramped up major, because tonsillectomies back in the day, they were then maybe in the hospital a week. How much time do you got to talk to the parent, make sure they're reassured, explain to them this, explain to them that. Now, you got to teach somebody who maybe has no medical knowledge, everything, you know, in hours.
They've been in and out with tonsils for a long time, because even when I had mine done forever ago, as soon as I woke up and was able to drink something, you know, see you later.
But look how old you are, you're very young.
I'm not that young anymore.
Yeah. Well, they do, I know in home health care, I went out and took care of a man who was crushed by a bowl in a arena, had all kinds of things, had all kinds of surgeries, and he was at home, and I was like, my goodness, I wouldn't even wanna take care of him in the hospital, let alone go in a home health situation and try to explain to the wife how to get him up to the bathroom. And so there is a lot more pressure to educate somebody who has no medical knowledge to be able to cope with, know, safety, when to call the doctor and all that. It's a lot more stressful to the nurse because you've got that compacted. And imagine it's like you're doing that day after day after day, and these people are coming in, going out, and you've got to do all that teaching, assess whether they can understand what you're telling them to do. So that is the short span of time that you have to get a great deal of information across to them. I think those are the biggest things that would change if you end up doing outpatient surgery. Okay, nursing responsibilities. This is just kind of a overview of the pre-op nurse. Advanced directives, informed consent, complete list of medications, blood donation if they're going to do that, assess risk factors, ensure diagnostic tests are completed, family is educated. You'll do a lot of educating before the person goes to surgery, and then preparation to get the person to the OR. So that's kind of a summary. Okay, for advanced directives, the biggest thing that you need to make sure is that if they have a living will or a durable power of attorney, that those are on the chart before they go into the surgery suite. So that's one thing that you will be responsible for. Informed consent. It talks about it in your book on page 55. And this is a very important area. You'll get questions on this quite often. The consent, you have to be very clear on what a consent is, who's responsible for what. Only the doctor is able to get a surgical consent. And you're thinking, well, I saw my nurse go in and get that consent signed, or I saw her getting the patient to sign that, or I saw the nurse talking about, different things that would happen. So the doctor, he just stepped in and he talked for a few minutes and out the door he went. But he is still responsible, okay? He is responsible that he talks to them about who is going to perform the procedure, what the risks are, that it's in a language that they can understand. It is his job to inform them of all those things. That is not your job. Your job is to clarify. If they have a misunderstanding of something, you can clarify what he said, but it's not your job to make sure they're informed about the procedure. Your job is to verify that the consent is signed. Okay, so you make sure that the right patient is signing it, that they're alert and aware. It's not an Alzheimer's patient that's sitting there signing something and he doesn't even know who he is, let alone somebody else. Or that they've been given some medication, pre-op med, and now that once you give a pre-op med, they cannot sign a consent, because that's your job to make sure they're alert and aware. And how do you determine that? So you're going to be doing that, make sure they're signing it voluntarily. Your job is to make sure that signature is viable, but that the person is truly signing that. If the patient isn't informed, it's your job to call the surgeon and say, patient up here really doesn't understand this and this. I think you better come back and talk to them. And then you document that. Does anybody got any questions on consents? Okay. There are, probably been in the past, reason this is so important, there are nurses that probably ended up either by default getting this dumped on them, or ended up taking on too much responsibility, and legally you want it to be the surgeon that is responsible. Okay, so you got your patient in there and you're gonna be responsible for kind of looking over the medications, making sure that the surgeon knows what medications there are and the physician has looked at that. But you're gonna wanna obtain a list of any herbal medications or vitamins. And check and see, you know, make sure they're not on an excessive amount of any of those. And then anticoagulants are important. You don't want somebody hemorrhaging during surgery. That's one of the risk factors that's pretty big. As far as the heart's concerned, your volume of fluid you have in your body, you want that to be kept adequate. You want to make sure the heart keeps pumping. So you got your heart and your lungs and your GI tract. Those are some things that you'll keep track of. Your heart and lungs are real important. So anticoagulants, you're going to make sure that those have been monitored. And so they'll do a PTINR or PTT. And do you think that would be elevated or decreased if it was, I should say, if you were going to have to call and say, hey, we may have to hold this surgery, something's looking not right. It'd be elevated. Does that make sense? What? Okay. Yeah. I don't think that'll be on board yet. So, okay, so aspirin is usually stopped about 5 days before surgery and NSAIDs. And then herbals and other things are at 2 weeks. Who can remember the things that are anticoagulants that are herbal that start with G?
Ginger, garlic, ginkgo biloba.
Garlic.
Yes. Okay, what about the E's? Do you know any of the E's? One of them's real easy. It's a vitamin. Vitamin E and echinacea. So those are 2 E's that thin blood. If somebody's got afibrillation and they're on Coumadin, they'll be evaluated by their PT or INR before they go to OR. If they're on any other blood thinners or if they have, trying to think of other.
Why do they stop fish oil before surgery?
It thins blood too.
It does.
Mm-hmm. Yeah. And this does happen. I mean, in pediatrics, I had a little baby that was supposed to go to surgery, and I look at the chart and it's got aspirin. I'm like, what? Are you serious? Well, sometimes the doctors are all hit and miss. You got 4 doctors taking care of one kid, and they're all writing orders, and nobody's paying attention to what each other's doing. And so, you know, I called the surgeon and said, you know, this guy's on aspirin, and so then it had to be taken care of. But, you know, you think it'd be a simple thing, but sometimes you get more than one doctor, you know, that's working with a patient. And so one doctor may order something and the other doctor doesn't realize it because he's only dealing with his own stuff, and that's very common. So if a patient's to continue on, say, a cardiac med, respiratory med, seizure med examples, they would be given that med if the doctor okays that with just a sip of water in the morning. So even though they're NPO, they would be able to do that. Okay, the diabetic patient takes insulin, may be given a reduced dose of intermediate or long-acting insulin. Okay, the surgeon, the anesthesiologist, they're the ones that okay all the meds, you know, and figure out if what's going on is appropriate. And actually, in your book, it talks about medication reconciliation on page 60, and you can go in there and read it in that section. Okay, blood donations, they may donate their own blood up to 72 hours prior to surgery if their hemoglobin remains at 11. The physician has to okay it, and they have to be infection-free. And family and friends can also donate blood, so. Okay, so in pre-op, you're gonna be gathering data just to make sure that the risk factors are, what risk factors there are and what has to be written in, maybe what the physician needs to be alerted to. So in your assessment, your age of your patient is gonna be significant. You know, if it's an elderly person, that's different than a middle-aged person or younger person. Allergies, these are the allergies that you'll need to know. The shellfish, that they might have, if they have an allergy to that. Providine, iodine, and contrast dye, they might be also allergic to that. And then bananas, allergy to bananas, might have a reaction to latex. And I don't think I've ever heard of anybody having an allergy to bananas. Drugs and substances, substance abuse. You'll want to know that. We'll talk about that more here in a minute. You'll want to do a medical history, family history. If there's family history of people not being able to tolerate anesthesia or different things, you know, you just want to be gathering data and make sure you know your patient for risk factors. If they have had any prior surgical or anesthesia experiences, how did those go? Okay. So as far as risk factors, if you want to look at page 58, 59, if you don't have it, you can look at it. These are some of the things, when you're assessing your patient, you're going to be focusing on these risk factors to see if you find any of these, because these would make a difference on how the patient's cared for. You can see this slide right here kind of has the most key ones, your cardiac, respiratory, kidney. And if you're looking at this page, you can kind of circle. You've got advanced ages up on the one side. You've got obesity, cardiovascular disorders, and then on the other page you have your respiratory. And those are some of the huge ones. Okay. As far as cardiac and respiratory problems, why would that be more of a risk for a surgical patient?
Anesthetic decreases their respiratory status already, it depresses it. So if they already are having a hard time breathing, if you put them under, it can slow respiratory failure and potentially die from it.
That would be a thought. Okay, so the anesthesia, it's a CNS depressant, and so since it's going to depress everything, it's going to depress respiratory, and it's going to depress cardiac. And then just the sheer trauma of the surgery, depending on the length of it and how much is going on, whether they have blood loss, those things are also a stressor. So with the cardiac, hemorrhage and heart failure are two big risk factors. And that's why you want to check the anticoagulants. And then respiratory, if the person's got, say, for example, COPD or things like that, exactly, you're going to have possible complications. And atelectasis is something, is the biggest thing you're going to see them talking about, you know, you end up with.
A lot of us actually got to see somebody that went into respiratory failure going into surgery. Because they went into surgery and they coded, and they, the OR ran them up, bagging them.
Literally.
We literally had them maxed out on epinephrine, norepinephrine, and butamine, and the blood pressure was still pretty well tanked. They said that that was basically the same thing as coding them.
She was on the vent with a PEEPA 12.
100% FiO2. It was crazy.
Wow.
She came around though.
Went to lunch
Yeah.
thinking that we were gonna come back and she'd be gone, and came back.
She
and
was
writing.
like-
Talking and writing.
It was crazy.
Yeah.
I've never seen something like that before.
I was bagging her
Not
up when
gonna
she
lie.
was gone.
Yeah, that is pretty intense.
Yeah. It was crazy.
Okay, so with that, preoperatively, you're gonna do a lot of teaching for post-op, because obviously you're gonna have so many patients that come out of the operating room and they're not gonna be really with it, they're gonna be still groggy. So you're gonna do teaching pre-op so that they're prepared to not have to have so much teaching afterwards. So you can basically remind them of some of the things you taught. So page 72 and 73 has cough, turn, deep breathe, information, and they get pretty technical about that when they ask questions, you know, how they like to ask numbers and stuff. So they'll ask questions, you know, about splinting or coughing or how often you do this or that or the other things. Encourage the patient to perform diaphragmatic breathing exercise every 1 to 2 waking hours depending on the patient's needs and the institution's protocol. And then steps 1 through 4 talks about how you precisely have somebody do coughing with splinting. So go through and read that. I know you had that last year, but just go through and read it and brush up on that. Okay, trick question. When you have an incentive spirometer to make the billows go up, do you blow into it or do you suck it?
Second.
Okay. That's always interesting, because if you haven't really seen it and you haven't paid attention, by now you guys are probably pretty good at this, but I've done simulations where people are teaching the simulator, you blow harder, and it was the whole group, and finally they got in a group and got together and talked about it, and they're like, oh no, you gotta, that makes it go up. So
What's the thing that you do when it makes the
Acapella?
yeah, so just get that straight in your mind. If you've never seen it, it won't stick with you exactly which way you're supposed to do it. Okay, so looking at your risk factors, the older adult, they're gonna respond a little bit slower, so especially like in post-op, they may not show signs of hemorrhage as quickly as a patient that is younger. Okay, you're not gonna have as quick a response possibly, and they're gonna have a lot of other things, decreased tolerance to anesthesia, for example, stuff like that. Okay, with obesity, there comes a whole bunch of different things. One of the biggest things is the wound healing. They have an increased incidence of wound dehiscence, infection, pneumonia, you know, alexis, thrombi, heart failure. Probably one of the bigger risks is like when you have when they have gastric bypass surgery, because they're so heavy. You cannot lay somebody with that much weight on their lungs. They have a hard time laying and not having difficulty, you know, expanding their lungs, and so they're really predisposed to getting alexis and pneumonia. They try to get them up pretty quick, but it's just a really tough surgery. So, then the cardiovascular, it's the things that we talked about, you know, embolism, stroke, thrombosis. Okay, and then respiratory, it's one of the most common risk factors that patients have. You know, something I haven't seen really questions on, but with the antidepressants, it says it increased the hypotensive effects of anesthesia, which would make sense. But I haven't heard that talked about as much as being a highly important thing. But I would go through, you know, malnutrition should make sense to you, poverty, alcoholism, again, you have a nutrition problem. So I would just kind of glance down through and just be familiar with, so if you see something, that you at least know what to do with it. Let's see on this next slide. It has substance abuse. They need more general anesthesia, delayed wound healing, neurological status. musculoskeletal problems. That would have difficulty if somebody's got really bad arthritis or different things like that, moving the person. Positioning the person in surgery, they may not be able to, you know, get into the position that they need to be in. And then psychosocial assessment is really important. If you have a person that comes in and thinks they're gonna die during surgery, that would make me really worried. That's not real helpful in having a good outcome. So you know, we talked about intervention for anxiety. Who remembers what you would do for anxiety, for the intervention?
Sedate them. I'm just kidding.
Yeah, you could sedate them or distract them, but
You mean like
teaching-
guided imagery?
Teaching helps. I mean, giving them information, facts, getting them comfortable with knowing, you know, what's gonna happen, where the family's gonna be, what the process is, when they're gonna go in, when they're gonna go out, the people will be with them, you know, all those different things. The teaching can really help with that, yeah. And then you can sedate them. Or distract them. That's another thing you can do. But
But it's sedation. Feel a little anxious, how about a little sedation?
so have most of you been to down to the surgical thing where they do the pre-op stuff, or has any of you last semester
In Maryville.
in Maryville?
Mm.
Some of you went down to St. Joe, didn't you, down and help with like starting IVs and yeah. So did you kind of see that there was a process that you have like a pre-procedure checklist, and it's pretty structured. Surgery has got evidence-based research that they have a list that they go through, a pre-op checklist, and there's just certain things that they go through and do in a very methodical order. And if you like structure, pre-op's a good place to go. It's pretty structured, it can be fast, but so you will make sure that the laboratory's done. Usually it's done a week prior. And so you'll make sure that that's on their chart, their CBC and H&H, clotting studies, if they might need blood, type and cross match, and all the rest of this stuff. And page 61 talks about diagnostic tests. You'll want those for a baseline. And we'll talk more about them here in a second. So, your chest x-ray. Your chest x-ray, you may have a chest x-ray done on older patients, those that have a risk of heart problems or lung problems. EKGs are ordered for patients who are undergoing general anesthesia if they're over 40 years old or have a history of cardiac problems. Renal function can be checked. So tests are ordered based on the history and physical prior to surgery. They like the hemoglobin to be above 8. And the hematocrit, like we were talking about, is usually about 3 times what hemoglobin is. Okay, so obviously, like the pulmonary function test, you know that would be done if there's a lung problem that they're worried about. MRI and CAT scan just depends on what the person's problem is and whether they're wanting to know exactly where to do the surgery, how to do the surgery, depending on the type of surgery. Here's some things that can be done for education. They'll have pamphlets, videos, written instructions. With kids, they'll bring them in and sometimes have a demonstration with a doll or take the kid through a tour depending on the hospital if they're kid friendly, I guess. You'll talk to them about their pre-op medications, what to expect post-op. That's real important. You don't want the person to wake up after surgery and wonder what in the world happened. We get used to that. We're used to seeing different things, but the patient may not be used to seeing drains and and different things hooked up, and the family may not be used to that. So you want to explain to them exactly what it's gonna look like with tubes and drains, pain, if they're gonna be on a patient-controlled anesthesia, you wanna talk to them about that. So during this time, you're gonna really want to encourage them to express their feelings. Talk about their fears or concerns. You wanna know those things so that you can address them. Try to use an open, honest approach that you know, not one that's judgmental or critical. You wanna be able to just, oh, that's okay, I've had other patients worry about that, or you know, that's very normal. You need to say words like that so that they feel like it's okay to ask questions and they're not gonna feel stupid or like they're inappropriate. You wanna clarify information and answer questions. Try to allay their fears. Family teaching is important too. So you wanna also tell the family that after, like for example, after the patient leaves the hospital room or admission area, there's usually 30 to 60 minute preparation time where they'll be in a holding area before they go to surgery. I mean, if somebody's really anxious and they think their loved one has gone to surgery, and then they find out an hour later the patient hasn't even gone there and they're in a holding tank, you know, area, then they're gonna be like, what? They haven't even gone yet, and I've been out here, you know, crying or whatever, depending on what's going on with the person. And then you'll want to explain to them that they'll go to the post-anesthesia unit for an hour or two after they've been in surgery, so that they kind of know what's going on. Down at St. Joe, you know, they have surgical units on this side, and then they got waiting room all the way down on the other side. And people sit out there and kind of wait. Okay, anxiety. Clients rank psychosocial support is the most important part of the preoperative teaching. And we just talked about keeping the client and the family informed. And helping them know where to go, explain the routines expected, which we just talked about. Okay, part of your pre-op is going to be doing whatever the surgeon's preference is and the type of procedure for intestinal preparation. Some of the risks with that would be it can cause electrolyte and fluid volume imbalances. Everything from discomfort, they got hemorrhoids, or orthostatic hypotension, vagal stimulation. But that is one thing, depending on how it's ordered, what's ordered. Skin preparations, the same thing. Different places are doing different things now. Sometimes they'll have them do a special shower the night before and the morning of, cleanse the skin. They'll use a special antimicrobial agent for showering. It's kind of controversial right now whether to shave. They feel like that exposes a person sometimes to more infections, maybe not. So if shaving's necessary, the CDC has that hair should be removed using a disposable sterile supply. Okay, the last few steps before surgery. On page 73 is where they'll talk about this pre-op checklist. It's down on the right-hand side. It's a preoperative surgical checklist, and it serves as an outline for finalizing preparation for the patient for surgery. So you'll complete the checklist before the patient is transported to surgery. And just to go through some of this, assist with the bathing or grooming, changing into their operative room gown. You also want to let your patient know to bring like clothing if they're going to have, you know, a cast on an arm or something, to bring some kind of clothing to wear afterwards so they can get over that device. Ensure that the patient takes nothing by mouth. That can be interesting at times. Because what some people think nothing by mouth is may not be what is nothing by mouth. I've heard some really funny things before. So you really want to make sure. They'll say, well, I didn't eat breakfast. Hello Kitty bar, you know, it's just funny what some people will think. So really make sure that you're talking communication with your patient, making sure that they haven't eaten. Remove nail polish, if nothing else, on one finger so that they can get a good pulse ox. Lipstick and makeup so that they can see their circulatory assessment. Ensure that their ID, their blood allergy bands are correct, legible, and secure. Remove hairpins and jewelry. Red wedding rings can be worn if they're removed from the finger and covered. Sometimes they can cover them with gauze and then replaced. Complete skin or bowel preparation as ordered. May have to put in a catheter or an NG tube. Remove dentures. You'll want to make sure that you know if there's any plates, dentures, those kind of things, because when they go into anesthesia, that they need to know what is going on with the teeth. Contact lenses. Sometimes they will leave in hearing aids if the patient can't hear, but you'll have to notify the operating room to make sure they know that and that's okay with them. So sometimes they'll take those out just very last. You'll need a baseline on the weight. Verify that the diagnostic orders are on the chart. Have the patient empty their bladder before they get their pre-op med, preferably. And after they get their pre-op med, they need to stay in bed and you'll put the rails up. So you want them to make sure their consent's signed and that they've used the restroom before you have them get their pre-op med. Record their vital signs for a baseline and provide ongoing support, and then you'll help transfer them to the OR. I think that, do you guys have questions on that area? I think that's pretty self-explanatory. Okay, of course you know that you always start discharge planning when you first get your patient admitted. So some of the things that they will have to do before they can be discharged is they'll have to be able to stand and begin to walk and not have nausea and dizziness, that the pain is controlled, they're able to urinate, they're orientated, and that they can demonstrate back any instructions that they need for their teaching. So one way that you assess or evaluate your teaching is you have them demonstrate back or explain back to you what you just taught them. Okay, here's a list of your nursing diagnoses that would go with pre-operative. So they would have knowledge deficit, possible anxiety or fear, possible ineffective coping, or spiritual distress. So you can see a lot of what you'll do pre-operatively is knowledge. You need to get your data, and they need to be taught a lot of stuff. So if you don't like teaching, I wouldn't say don't go into day surgery where you've got to be working with people every day, because you will be doing a lot of teaching. Okay, so now the person's done in pre-op, they're ready to go into intra-op, and the focus in intra-op is keeping the environment and the client safe. That is the nurse's job. You need to be aware of conversations that are being had, physiological monitoring of the patient, and then the patient is usually given anesthesia. It can be general, regional, or conscious sedation. And then there's 3 phases of anesthesia: induction, maintenance, and emergence, and we'll talk about those. You have to have a general understanding of 3 phases of anesthesia, but you don't have to get super technical on that. Just have an understanding of those concepts. Okay, surgical risk. You have infection, risk of infection, impaired skin integrity, increased anxiety, altered body temperature, and injury related to positioning. So page 70 has positioning, and in intra-op nursing, you are responsible for making sure that patient is safely positioned. What do you think would happen if you had a 250-pound woman and for some reason you had her hand stuck under her side for 3 hours during surgery?
Circulation.
Yeah.
Do you see how that could be a problem?
Yeah.
Yeah. That wouldn't be a good thing to find that out after surgery, that you had mispositioned the person or something, because that person cannot move themselves at all during surgery. They are unconscious if they're in general. And so you are responsible for that. Okay, so on 70, if you see, you'll need to know some of these. What is the risk factors with these and what the safety is. So you got dorsal recumbent or supine, and that is a pretty typical position. If a person is obese, that's a difficult situation. If you look down here in the lithotomy position, which is E, the struggle with that is if you had somebody who's pretty heavy, that could cause respiratory compromise because they're on their back and their legs are up. Let me see if I can. You'll need to know a Trendelenburg and a reverse Trendelenburg position. What that means, a Trendelenburg is where the head is down, the feet are up. A reverse Trendelenburg is where their head is up and their feet is down. They're at an incline. With a lithotomy position, this would be one where if a person had arthritis or something, this would be a very difficult position, and there can be joint damage and nerve damage. So they have special recommendations, evidence-based, for like padding in different positions, and how long they can be in those positions. Like the semi-sitting position, that one there needs padding, and they can have skin breakdown on the buttocks and venous pooling, hypotension. Lots of times you can pretty much figure out mechanically what's going to happen with somebody. Okay, nutrition is on page 71. We talked about that the other day, and you were right in the back row, whoever said protein. Protein, calories, vitamins, hydration, water. They'll need hydration. Those are the big things that help with wound healing and healing from surgery. Okay, let's talk a little bit about, there's a surgical care improvement project, which in your book is on page 56. And this was after they had so many complications, surgical complications, that they started, they had a project that looked at the risk factors and used evidence-based research to support the interventions that need to be done to prevent complications. So surgical site infections, deep vein thrombosis, cardiac events, urinary tract infections, they have evidence-based research for interventions for those different areas. It talks about a little bit more on page 61. Like, for example, under surgical site infections, the SCIP guidelines are prophylactic antibiotics in select procedures, appropriate hair removal, and glucose control in patients having major cardiac surgery, and normothermia in patients, that means you keep their temperature in a normal range, in patients undergoing colon surgery. So they got evidence-based research, and they'll just have guidelines, and they'll just follow them. Okay, you do this, this, and this. If you have this type of surgery, you'll have prophylactic antibiotics. And it's just a way of having better outcomes. So, okay. So members of your surgical team, you got your surgeon, anesthesiologist, or a certified nurse anesthetist, and circulating nurse, scrub nurse, possibly a surg tech. Okay, the surgeon's responsibilities. You'll need to know the responsibilities of the different team members. The surgeon assumes responsibility for the surgical procedure. So he focuses in mainly on the surgical procedure. Sometimes there's a surgical assistant, and basically they help the doctor. It could be a different number of types of people, and they assist the surgeon. You don't need to know that as much, but there's somebody that assists. They may hold the retractors or suction the wound or those kind of things. Then you have the anesthesiologist. And the anesthesiologist specializes in giving anesthetic agents, transfusing blood products, monitoring the level of anesthesia, and the cardiopulmonary function, vital signs, input, output, IV fluids. So his job is, and responsibility, he relieves the surgeon of the responsibility for the patient's well-being, allowing the surgeon to focus on the procedure. So he's constantly monitoring the patient's status, and he will let the surgeon know if things are going wrong, things, something's changing, and then he will treat that. He supervises a patient recovering PACU also, so they'll get a hold of the anesthesiologist if they're having a pain control issue or if something happens. So for example, the anesthesiologist really is the one that has to care about that patient, that they stay alive, that they're doing okay, that their heart is good enough for surgery. So like if you had, let's say you had a patient that was extremely anxious, just really thought they were gonna die, just couldn't get them under control. You would get a hold of the anesthesiologist and let him know that, because it might take more anesthetic agent to put that patient under because they might be fighting the anesthesia, or there might be a problem. Everybody has normal anxiety, but there is excessive anxiety. You would notify, like if they're have decayed teeth, loose, if they have a tremendous amount of herbal use. There's been people who died from like being on too high a dose of some herbal agents that are anticoagulants, vitamin E. Sometimes people take way more than they're supposed to of something because they don't understand, and it's like, I mean, medications do come from a natural source unless they're synthetic lots of times, so it has some tendencies that it would be like a medication in some ways. So okay, the circulating nurse. The circulating nurse coordinates activities in the OR, including that it's clean, the lighting, humidity is correct, safety of the equipment, assisting the team members, including the anesthesiologist. Circulating nurse monitors asepsis in the OR. Who's seen that? Go on. What did you see when you saw circulating nurse watching for the asepsis in the OR?
I've seen them tell them before that they broke
Yeah.
sterile field, yeah.
It's
Yeah.
kind of like a hawk in there.
Mhm.
I mean, they, you know, from talking to circulating nurses that have been there a while, they can be standing on one edge of the room and they can know almost when somebody's broken sterile technique on the other because they're just like so adept at their job. And that is their job. And if they call it, it has to be done. And that's their job, is the safety of the patient. So they position and they complete the prep of the patient's skin. So they position the patient. Okay. Okay, they will also do documentation. They'll document the intraoperative nursing activities, medications, if there's blood administered, if there's drains or catheters that are placed during surgery, the length of the procedure. They'll help with the count of sponges and instruments. They actually do the count, the other person helps. Formulates a care plan based on physiological and psychosocial assessment of the patient. They advocate for safety and well-being of the patient at all times. Okay, then you also have the scrub nurse. The scrub nurse sets up the sterile field, drapes the patient, hands sterile supplies and instruments, equipment. She has or he has a knowledge of the surgical procedure, so she can anticipate what needs to be handed to the surgeon, what the surgeon's gonna want, the type of sutures maybe that he'll want. This cuts down on the time that the patient has to be under anesthesia. She almost can anticipate what the surgeon wants.
Isn't a lot of that done by the OR tech now?
It could be. All I know is you definitely want to know what you're doing because most surgeons are very particular. They want somebody that knows what they're doing, and they're many times not real easy on students or other people if they help in some ways. They pretty much want their stuff in their hand the way they want it when they want it. And there are some people who are really good at doing that. If you're not good at that or remembering stuff or anticipating somebody's needs, it might not be the job for you. But some people just love it. The surgeon's anxiety and tension can be decreased, especially in tough surgeries. I mean, I don't know if you've seen Gifted Hands, where he separated the two babies that were conjoined at the head. There's a movie out on that. And they had double team in the room because once they split the kids apart, they had to have a full team around each one, and they had to stop their hearts. You know, in a case like that, the surgeon needs to know that whoever's around him is confident and is going to be there to anticipate what he needs. So it can decrease the surgeon's anxiety and tension. The scrub nurse works closely with the circulating nurse, helping count sponges, setting up sterile fields, draping, keeping count. If I am correct, I believe when they started doing scanning at airports is when they started finding that there was a lot of things in people, and so they got a little bit more careful about counting things. Because they started having people go through these things and they were seeing things left behind, I guess. Okay, safety in the OR. They have a certain layout that prevents infection. It limits the traffic that goes in and out. They have electrical safety, grounding pads. Equipment has to be safety checked. I was looking online, it was talking about fires in the OR because, you know, they cauterize, they've got oxygen in there. So there's different things that need to be kept safe. Equipment is sterilized, that there's a correct count. Now timeout, the nurse is an important part of this safety measure. It's called timeout. Before starting the OR procedure, a timeout procedure is called at a minimum. The patient's identity, the correct side or site is checked, the correct patient position is checked, An agreement on the proposed procedure and availability of the correct implants and equipment must be verified by all members of the surgical team. And there's just like lots of stories on that. You know, a guy that had lung cancer on one side, they went to take out his lung and they were done and they had taken out the wrong lung. That's because the CAT scan picture was flipped and they just didn't know that. That was probably not a good day for a lot of people. They've taken off wrong limbs. I can remember back in the day, years ago, my dad went in to do surgery to do an appendectomy on this kid. He went in there and there was an appy scar on it, and this old codger, he was like 100 years old because he'd gone out to Kansas in this desolate area. This guy was still trying to practice medicine. He'd already done an appendectomy. It was already done, so he's like, so these things happen. So just be particular. I mean, you know, for one thing, I know, like my husband has allergies, and people just kind of blow off allergies because everybody thinks they got allergies nowadays, but he's actually almost died from penicillin. He's almost died from Cipro. He's been in seizures all night from Phenergan. He had, he almost goes into seizures with Benadryl, and you wouldn't think Phenergan would be a problem. But I saw him, he's going back to procedure, and I said, where's your armband? Well, the guy goes, the guy that was taking him turned to me and said, does he have any allergies? And I'm like, yes. So it just, I think people are busy, understaffed, and so just do your part to make sure you're careful with safety. Okay. We'll talk about surgical scrub. You guys should be familiar with this by now. That's just you take off your rings, watches, bracelets, no artificial nails, and you do a scrub for 5 to 10 minutes, fingertips to elbows, and after scrubbing you hold your hands up and you will be washing. I'm sure you guys have witnessed this by now. And then they go in and they're dried off and gowned by somebody. That would be what a surgical scrub is. And then the areas of the surgical gown considered sterile are the front of the gown from 2 inches below the neck to the waist and elbow to wrist area. And if you remember, anything below a counter is going to be contaminated. Consider anything below waistline, anything that's out of sight. So they consider that to be not sterile. And you don't turn your back on a field. I think those are some of the basics. Okay, that's just considered surgically clean. It's not sterile. I think you should know the difference between that by now. Why don't we take a break? We'll talk about anesthesia a little bit when we get back.
Do you want these that we did earlier?
Yes, I want them at test time.
Okay.
Yesterday was